learned chairperson, and distinguished delegates. Professor Beasley was the first person to discover that a virus can lead to human cancer. Beasley and his colleagues proved that hepatitis B virus is a primary cause of hepatocellular carcinoma. He suggested that the path of transmission is from mother to infant during childbirth. Working in Taiwan, he concluded that 1 in 4 male carriers of hepatitis B would die of hepatocellular carcinoma. I work in India. India has a population 50 times larger than that of Taiwan. 4% of Indians are hepatitis B carriers. If we extrapolate the Taiwanese figures, it would mean that 250,000 people would die in India each year from hepatocellular carcinoma. This was a projection made by Dr. Miller of the CDC. Data from the Indian Cancer Registry maintained by the Indian Council for Medical Research suggests that only 5,000 actually die of hepatocellular carcinoma each year. The reason for this disparity between the projected figures and reality is not clearly understood. It is assumed to be because of differences in the strain of virus affecting Indians and that affecting Taiwanese people. Strains A and D affect Indians, while the strains in Taiwan are said to be strains B and C. How the strain matters is, however, not clear. Hepatocellular carcinoma develops in chronic carriers of hepatitis B infection, meaning that the body cannot get rid of the virus. 90% of babies who acquire hepatitis B at birth become chronic carriers. Only 2% of those who get hepatitis B as adults become chronic carriers. So vaccination is advised starting at birth to prevent mother-to-child transmission and to reduce the numbers of chronic carriers. However, in India, 40% of our deliveries take place in distant rural homesteads outside of institutions and hospitals. It is nearly impossible to reach these babies within 48 hours of delivery. We in India have therefore adopted a pragmatic approach to vaccination. We vaccinate babies born in the hospital at birth, and those born at home, we vaccinate them when they come for the DPT vaccination starting at 6 weeks. This program has been going on for over 10 years now. This study, funded by the Indian Council for Medical Research, was conducted to see if the birth dose was crucial and whether we needed to change our policy. We did a case control study. We examined children to see whether they were HBs antigen positive, meaning that they were hepatitis B carriers, or whether they had antibodies to HBc, the core antigen, which suggests that they were infected in the past but have cleared the infection. We looked at this against their vaccination history to see whether they were vaccinated at birth, whether they were vaccinated starting later in life, or whether they were not vaccinated at all. We also looked at the antibody to surface antigen, which is a marker of vaccine uptake. We studied 2,675 children. 59% of them were fully immunized, which means that they had received all 3 doses. And of these, 56% of them had received the birth dose. Results: there was no reduction in the carrier rate or the infection rate in those who were vaccinated starting at birth compared to those vaccinated but starting at the age of 6 weeks. This suggests that we do not really need to give the birth dose in India. However, protective antibody to surface antigen was present in only 70% of those who were fully vaccinated. We expect at least 90% of them to be protected, but we found only 70% protection. Among those who were unvaccinated, 40% were immune. This immunity found in unvaccinated newborns must be passively acquired immunity which they have received from their mothers. As these mothers are unvaccinated, because no vaccine was available in those days, it must reflect antibodies acquired by mothers after natural infection. The antibody to surface antigen in the unvaccinated reduced with age, suggesting again that this passive immunity acquired from mothers declines slowly as the child grows older. High levels of antibody in unimmunized babies was previously documented in another ICMR-funded study by Agarwal et al., who studied children who were 5 to 10 years old and found that 20% of them had naturally acquired immunity, meaning they had antibodies to surface antigen although they were unvaccinated. Remember, we started by saying that the incidence of hepatocellular carcinoma in India is much lower than what was expected. Now we probably know the reason why. The strains A and D are easily transmitted from person to person. Most mothers, although they were not immunized in those days, have got natural infection and have developed antibodies. This is passively transmitted to their babies, and the babies are protected in the first year of life when the chance of developing hepatocellular carcinoma is the worst. Later, this immunity wanes and the child gets natural infection and actively develops antibodies, and these are passed on for protection of the next generation from hepatocellular carcinoma. This hypothesis is a new hypothesis and is supported by the findings of antibodies in 20% of children examined by Agarwal et al. If this is true, then vaccination will reduce this natural immunity and the protection it affords to newborns in the first year of life. And paradoxically, once we start vaccinating the population, as natural immunity comes down, there may paradoxically be an increase in hepatocellular carcinoma in the population that is not fully vaccinated. That brings us to the title of today's talk: High levels of natural antibody to surface antigen in newborns in India may provide protection against hepatocellular carcinoma. On behalf of the study team who conducted this ICMR-funded study, I thank you for your attention. Thanks.